Welcome, everyone, and thank you for joining us today. My name is Helen Angus. I'm the Deputy Minister of Health. I'm joined here by several colleagues from the Ministry: Mel Fraser, Associate Deputy Minister of Health Services; Phil Graham, Executive Lead of Ontario Health Teams Division; and Amy Olmsted, Director of the Home and Community Care Branch. I just want to say thank you for joining us on very short notice. The legislation that we're going to talk about was introduced about an hour ago, and we want to make sure that we had a chance to reach out to you as quickly as possible. Also, this call is being recorded and will be available online in the coming days. We're very pleased to share information with you about the government's plan to modernize home and community care and answer your questions. We'll have, I think, many opportunities in the future to engage in the coming weeks and months. So if we aren't able to get to all your questions today, there'll be other opportunities for discussion as we move forward. You can submit questions electronically by simply clicking the question button. So earlier today, the Honourable Christine Elliott, Minister of Health and Deputy Premier, introduced legislation, the Connecting People to Home and Community Care Act, in the legislature. This proposed legislation, if passed into law by the legislature, would enable more flexible and responsive home and community care, integrated at the local level by Ontario Health Teams. Ontario has the largest home care system, both overall and per capita in the country. Last year, more than 700,000 Ontarians received home care, and over 600,000 Ontarians used community support services such as Meals on Wheels and adult day programs. Ontarians receiving home and community care services include patients returning home from hospital, people requiring longer-term support at home, such as seniors living with frailty, children living with medically complex and palliative conditions, and palliative patients who wish to die at home and in hospice. I want to thank the personal support workers, therapists, nurses, care coordinators, planners, navigators, and other professionals whose commitment and dedication supports the delivery of these services every day. Home and community care services are crucial in the government's plan to end hallway health care. The government has heard about the importance of home and community care. They've also heard from patients, families, and health system partners that the system could be better integrated, more flexible, and more responsive. The government has a comprehensive plan to modernize home and community care, and the legislation that was tabled just this afternoon by the Minister is part of that plan. So I'll hit some of the highlights and then I'll hand it over to my colleagues to go into the details. The proposed legislation is intended to make it easier for people to access home and community care in hospitals, primary care, or community settings. It's designed to help people connect with their care providers through secure technological mechanisms such as remote monitoring devices. It's designed to give people more choice for people with high care needs to get care in new community settings. And it's designed to keep people healthier at home by empowering care teams to work together. Of course, changes won't happen overnight. The transformation is a process, and one that requires careful planning and partnership with people like you, patients and caregivers, health system providers, health workers, and their representing organizations, and health system managers and planners. Today, with the introduction of the new proposed legislation, we mark a milestone in this transformation. And with that, I will invite Phil Graham from the Ontario Health Teams Division here at the Ministry to say a few words about the impetus behind the modernization plan. So Phil, over to you.
Thank you, Deputy. Good afternoon, everyone. The proposed Connecting People to Home and Community Care Act is one pillar of the plan for the modernization of home and community care in Ontario. The proposed legislation would, if passed, remove long-standing barriers and outdated rules that have kept home and community care from integrating with other sectors of our healthcare system, and would bring the legislative framework for home and community care into the 21st century. The current legislation, called the Home Care and Community Services Act, and the delivery model that has developed alongside it, were created in the early 1990s. They were successful in delivering on the original aim, which was to streamline what was seen as difficult and inconsistent access, as well as variability of care. However, the current legislation and the current delivery model it supports has not kept pace with the changing demographics, the increasing client acuity, client preferences, and innovation. The legislation has been perceived as rigid and reinforces silos within the current health system and often creates bureaucratic barriers to accessing care. This is a message that we've heard for some time from patients, caregivers, from providers, and more recently from Ontario health teams as they've been undertaking work to better integrate care locally. The proposed legislation seeks to preserve what is working well in home and community care and create the conditions for improvement in areas where we know we need to improve. Some examples that we've heard from clients, families, and health system partners are that the rules currently in the legislative framework reinforce a one-size-fits-all approach to care, that patients have to interact with the home care system separately from how they interact with primary care and hospital care, and that care plans focus largely on number of hours or visits instead of patient and caregiver goals and outcomes. So how are we considering addressing some of these issues? I'm going to take a minute just to talk a little bit about the proposed legislation that the minister tabled this afternoon. The legislation would embed provisions regarding the delivery of home and community care in the Connecting Care Act, instead of having a standalone home and community care legislation. Many of you may have participated in a telephone town hall, as we're doing today, when the Connecting Care Act was introduced last year. And this integrating home and community care as part of that legislative vehicle would recognize home and community care as a vital part of an integrated healthcare system. The proposed legislation, if passed, would remove several restrictions on the model of delivery that we've heard from patients, caregivers, providers, and Ontario health teams that are quite constraining in terms of moving this sector closer to where patients routinely access their health care. It would make it possible for care coordination functions to be provided at various points of care within the healthcare system, supporting care decisions to be made closer to the patient. This would also reduce duplication and some inefficiencies in the care coordination process. The legislation, if passed, would also allow more flexibility in care planning, allowing quicker updates to care plans to respond to patients' needs, and removing the requirement for patients to have multiple care plans and multiple assessments from the LHIN, from service providers, and others to move towards one plan of care centered on goals and objectives for patients and caregivers. The legislation, if passed, would also add an oversight model for residential congregate care. This is a first step to developing future options of bedded models in the community for patients with needs too high to be well cared for at the home, but who don't require the intensive level of care provided by a hospital or a long-term care home. These are pretty major changes, but for the most part, they won't change what services patients receive, but make critical and needed changes to how they receive these services. And this is a message that we've heard from providers, including Ontario health teams, that the role of the ministry should not be to both define the what and the how of healthcare, but to focus on the what and to allow for innovation to take form locally in terms of how care is delivered. There is a lot that we're looking to preserve, either in the proposed legislation or in proposed regulations. So what do we expect to remain the same? One is the types of services provided through home and community care. These are services that over 700,000 clients annually rely on, and we don't want to change that. We want to make sure that service continuity remains of paramount importance. Home care services that are delivered without patient co-payments now would continue to be delivered without co-payments. Health service providers or Ontario health teams with responsibility for providing home and community care services would be required to be not-for-profit organizations, just as LHINs are today and as approved hospitals are that provide home and community care services today as well. The legislation, if passed, would not specify the service model, but we expect that home care services would continue to be primarily a contracted model with both for-profit and nonprofit organizations delivering home care. Community services, such as Meals on Wheels and assisted living, would continue to be delivered directly and provided by not-for-profit organizations as they are today in almost all cases. The ability to set quality standards, oversight, and accountability and core elements of the current home care program would be maintained, again, to ensure service continuity and stability. A patient bill of rights and a complaints process for home care to be included in regulation would also continue to provide a clear process for patients for resolving issues that they do experience. Patients would continue to have the right to appeal to the Health Services Appeal and Review Board regarding eligibility, type, amount, and termination of home care services. As well, patients would continue to have access to the patient ombudsman as they do today. While the legislation is being considered by the legislature, the ministry is also posting summaries of proposed regulations related to home and community care. This will be, or actually is, on the government's regulatory registry. You can look it up through Service Ontario up until early April for public feedback. This is to ensure that our partners have a comprehensive view of the legislative and regulatory framework that is being proposed, with the legislation that the minister tabled earlier this afternoon and the simultaneous posting of summaries of regulation also accessible today. Much of the key components of what I've just described in terms of what is being proposed in a new, more modernized legislative framework would be in regulation. And this would ensure a strong but flexible framework going forward. A small but important part of the proposed legislation is around the name of Ontario Health Teams. The proposed legislation clarifies that only designated Ontario Health Teams or those of teams with express authorization from the minister, such as those teams working towards OHT approval, can use the Ontario Health Team name and provides the ministry recourse if non-authorized parties are using the name without permission. The Ontario Health Team brand has become quite recognizable in Ontario, and this provision, if passed, would ensure that that name can be protected and used only for its designated purposes. We are also proposing to replace the term Integrated Care Delivery System, which is currently the legal term for Ontario Health Teams embedded in the Connecting Care Act, with the term Ontario Health Teams. This is really simply to address any potential confusion arising from the use of different terms, but does not in any way change the status of the 24 approved teams, nor those working towards becoming approved teams. The ministry will continue to work with all Ontario Health Teams and others on the readiness pathway as they continue to work towards achieving approval. Another topic I wanted to touch on, which is not related to the legislation, or not part of the legislation rather, but is a critical part of the government's plan for home and community care over the next few years, is the Local Health Integration Networks, or LHINs. We recognize that the next few years will be a time of transition, and we are trying to strike a balance between enabling innovation while at the same time preserving stability and maintaining uninterrupted access to care. The government and the minister has been clear that Ontario Health Teams at maturity will be responsible for the delivery of home and community care as part of a more integrated approach to service delivery. In the interim, while these teams are being established, the existing 14 LHIN corporations will be maintained. The mandate of the LHINs will be narrowed to focus solely on the delivery and coordination of home and community care and long-term care home placement services. To reflect this mandate and to clarify their role for the public, the LHIN corporations will begin operating publicly under a new business name called Home and Community Care Support Services, along with the current LHIN geographic identifier. We expect this change to take place over the next couple of months. This approach of maintaining the LHIN corporations, but with a new business name, is a measure to ensure the stability of home and community care services during the process of transitioning these vital services closer to the point of care nested in Ontario health teams. Through this interim and transitional measure, the government would be taking a phased and careful approach to winding down the LHINs as we know them today. This work will be complete once Ontario health teams have fully assumed the delivery of home and community care services across the province. And it is expected to take time to ensure that this transition process can be done carefully and with due attention to ensuring stability of service over this process. During this transitional period, patients and caregivers can continue to access home and community care and long-term care home placement services in the same ways they have before, using the same contacts. And this is a vital message to ensure that we all leave here today with, to ensure that there is no confusion and no misunderstanding about access to these vital services. The proposed legislation and the strategy to support stability and care during a transition process are two elements of the plan for home and community care modernization. To be clear, we don't think that this is the end of that plan, and there are other areas where there is room for improvement and modernization. And the government will be taking action on other fronts, including making targeted financial investments, as well as tackling workforce shortages that are challenging the current home and community care delivery system. Our overarching objectives are to improve patient access to and experience with home and community care, improving health outcomes, making health spending more sustainable, and improving the patient and provider experience. So I want to thank you for your time today to be with us, and again to echo the Deputy's apologies for the short notice, but we do appreciate you being here, and now we are happy to take any questions that you may have. Thank you.
Okay, so the first question that came in is that you mentioned a few times that protecting patient care is your top priority. But how will the ministry ensure care is not interrupted and services are lost? Is there a transition plan in place? Can we get more information?
Thank you for the question. I think I'll start off by, and at risk of repeating, is talking a little bit more about maintaining the LHIN structures that are in place as we work to transition home and community care into Ontario health teams. This has been a deliberate decision for the sole purpose of maintaining service stability. So the employment relationships between LHINs and hardworking staff across the province, the collective agreements that govern those relationships, the service contracts that LHINs hold with home care service provider organizations will not change in the near term, nor as a result of the legislative proposals being tabled today. And this is for the sole reason of ensuring stability of employment, ensuring stability of service for home care clients across the province. Over time, yes, we will see a gradual and phased transition with home and community care being nested closer to the point of care within Ontario health teams. And a lot of work has to be done with LHINs and under their new business name, with frontline service providers, with Ontario health teams, with patients and caregivers to make sure that transition can happen as smoothly as possible. We'll be honest, we do not have all the answers today, but I think our commitment is to engage thoughtfully and carefully in that transition process, to be as transparent as we can be in that transition process, and first and foremost to make sure that transition process does not disrupt any services that home and community care clients rely on each day.
The next question is, it sounds like you're creating another version of a CCAC. Is this another layer of bureaucracy?
Thank you for the question. It is not another layer of bureaucracy. There are structures that exist today, 14 LHINs who are responsible for delivering and coordinating home and community care, as well as long-term care home placement services. Those structures will remain. So it's not new bureaucracy. It is maintaining the structures that do exist, focusing the mandate on home and community care and long-term care home placement, working with Ontario Health as a new provincial agency to ensure system oversight and operational support is provided to the healthcare system. But to be clear, this is not new bureaucracy that's being created. It's a focused role for the existing structures that are in place, and again, are to ensure stability of service during a transitional period as we move to embed and integrate home and community care closer to where patients are accessing their routine healthcare services.
The next question is, will there be a co-payment for new patients coming on for service?
No.
No.
It's an important question, and I'm actually glad it's asked because, again, to ensure a clear message from all of us to patients and families who are relying on these services, the proposed legislation does not introduce any changes to existing co-payment mechanisms, which for home care means no co-payments, and for community support services, some co-payments, but no change to where that may exist.
The next question is, can you please discuss in more detail what the role of the care coordinators will be?
I'll start off, and Amy Olmstead, who's been doing a lot of work here, can contribute or correct me where I go wrong. I would say that the role of care coordination is a vital one. And increasingly, as we see the complexity of patients rise, as the demands for home care rise, and as patient expectations reflecting modern delivery, we would expect the need for care coordination to be ever present in our healthcare system. This would be perhaps care coordination beyond coordination of home and community support services, but coordination across hospital care, home care, primary care, specialist care, and the range of different services that particularly those with complex health needs may need to access as part of their overall care plan. And the role of care coordination within that context is one that brings often disparate services together into a unified care plan that is centered on the objectives and goals of patients and their caregivers. And so while care coordination remains a vital part of our system today and will continue, we do think that there are opportunities to better integrate that function into where patients are accessing their routine health services, removing some of those barriers, and some of them quite artificial, that patients are experiencing having one care plan with one provider, another care plan with another. And it's really the role of care coordination that can bring those together. There may also be opportunity to modernize that function relative to how it is today, with the use of virtual tools and other modalities to streamline that process, to make it more client-friendly, and overall to help look at a situation or arrive at a situation where patients and caregivers are not having to repeat the same story over and over again. And so care coordination plays a vital role in that. We have a lot of work to do to identify where those opportunities for improvement are and to work with our partners to implement those. But I think the role that care coordinators play today is a vital one, and we certainly see a very strong role for that going forward as well. Amy, anything to add?
Yeah, thanks, Phil. I think the care coordination functions, as Phil says, will remain core to home and community care service delivery. Those functions include intake, eligibility assessment, needs assessment, care planning, care allocation, arranging care, oversight of care, and updating assessments and care plans as needed. Those are all core functions that are very important to any type of care anywhere in the system, and certainly for home and community care. We also know that LHIN care coordinators do have additional functions related to arranging for the Ontario Drug Benefit, supplies and equipment, managing issues on the ground with service as well, and addressing complaints. So these are very important functions, and as Phil says, the goal is for those functions to be arranged in a way that make the most sense for the patient, the particular type of patient being supported. They may look different for a complex patient than for a patient without very much complexity, and that will make sense for the health system partners in that particular community. So how those functions are arranged will vary. The legislation will not mandate a particular model of how those functions should be performed. We want OHTs and other partners to test new models, to evaluate those models, have shared learnings about what practices work well and what don't work well, so that as a system, we can better meet the needs of patients in a way that is efficient and effective, transparent and understandable for those patients and caregivers, and best supports that integration and connectedness for patients and also for the care providers on that team.
The next question is, will the function of long-term care placement also be moving to OHTs eventually, or will that be centralized? Example, one waitlist.
Yeah, so I think we're looking forward, it's Helen, to working with our colleagues in the Ministry of Long-Term Care to get their thoughts on how the long-term care placement function would be, I guess, best delivered in an OHT model. We know that many people want to move to be closer to their children, when they're looking for long-term care, and may not, want to stay within a particular OHT, and we want to make sure that people have access to the full range of long-term care options. And so we want to make that easy for them to do that. So I'm sure that, that's a design feature that I think we've got some work to do, and certainly look forward to, thoughts and ideas from the sector and from patients and families. And as I said, we'll be looking to our colleagues in the Ministry of Long-Term Care to give us some guidance on that, and I'm sure they'll be working on that with you.
Next question and comment. Bravo on the new legislation. How will the proposed changes impact community support services?
Great, thank you. It's Amy Olmstead speaking. The range of community support services would be proposed to remain essentially the same, with delivered by the same types of partners in communities that we have today. As with home care, the goal would be over time to better integrate those services into the broader system, and that would be done through Ontario health teams, and more closely facilitating those relationships and partnerships. We know that community support services are caring for people with surprising complexity, and that for those clients in particular, though, that integration of care is really, really important, and that's what we hope the legislation will facilitate.
The next question is, what do you foresee as the role of service provider organizations in the context of OHTs?
Thank you for the question. It's Phil speaking. So for everyone's benefit, service provider organizations play a very important role in home care delivery, often operating under contractual arrangements with the LHINs, personal support workers, nursing therapies, and other supports being delivered in the home is a key role that service provider organizations currently play. And we see that role very much continuing within the Ontario Health Team context. Where we see potential changes, again, is not so much in the what, but in the how. We may see somewhat different arrangements emerge across the province to make sure that those relationships with service provider organizations and those services being delivered very much adapt and respond to local circumstance and local context. within a frame of general consistency, so that patients in Kenora can expect, at a minimum, a similar level and type of service to those in Ottawa, Toronto, or London. And so we don't see necessarily drastic changes in terms of those relationships with service provider organizations and the roles that they play. We've heard a lot of feedback from Ontario health teams in particular around the need to perhaps take a look at those contracts to make sure that they are aligning with the outcomes that we are seeking to achieve around, better efficiency, better outcomes, better patient and provider experience. But I think, as with the role of care coordination at the present time, we have a strong desire to ensure stability of service for the work that service provider organizations do. And we'll be learning a lot from Ontario health teams in terms of how they foresee that relationship being forged and changing in the future.
Can I add something, Phil? It's Amy Olmsted speaking again. As we've worked with our health system partners and patients and caregivers over the years, the opportunity to have different delivery models does extend, as you say, Phil, into the contracts and the way services are contracted right now. A lot of those services are contracted on a per visit or hourly basis. Sometimes people refer to those contracts as feeling somewhat transactional. And I think one of the goals of the legislation in promoting more flexible and innovative and responsive delivery models is that as those models are conceived and planned, the contracts would be flexible enough or would be reviewed or updated to reflect new types of delivery models on the ground. And that may be a pathway-based model or a neighborhood-based model or an outcomes-based model. And I think what Phil was foreshadowing was some of that work is still to be done because, again, it will be driven by the types of models that the Ontario health teams are seeking to put on the ground to better respond to patient need.
The next question is, there are still so many citizens who do not have a primary care provider in Ontario. The success of this model is dependent on clients being attached to a provider. What is the plan to ensure everyone has a primary care provider?
So I'll give it a try, and then
Sure.
maybe Phil can jump in. I think, we're certainly working very actively on a health human resources plan, and I think are excited about the possibilities and the government's interest in really kind of getting ahead of, some of the supply issues, whether that's physicians, whether that's nurses, whether that's PSWs. We know where some of the hot spots are, where we're particularly capacity challenged. And I think that one of the roles of Ontario Health, since they now incorporate Health Force Ontario inside their walls, is to expand that capacity so that we can bring some innovative solutions to some of the challenges. And in that, I would also include, primary care practitioners. That may be family doctors, it may be nurse practitioners as well. And so we're working on it, and stay tuned.
I think that's great. I would just add that, over the past decade and a half, I think Ontario in particular has made considerable progress in ensuring Ontarians have access to a primary care provider. I think the attachment rate that we have self-reported is one of the highest in the country, in the 92, 93, 94% of people identifying that they have a primary care provider. I think, as the deputy mentioned, where the challenge is sort of region specific, and warrants, as the deputy mentioned, in partnership with Ontario Health, perhaps more targeted efforts where, identifying where those hotspots are, what levers and tactics can be employed to, enhance primary care capacity in those particular areas. It's important to clarify that as it relates to access to home and community care, it does not necessarily require a referral from a primary care provider or a hospital. Patients and clients today can self-refer by direct access to the LHIN, and nothing in the proposed legislation changes that ability of direct referral to home and community care. So I think that's an important clarification that while Ideally, 100% of Ontarians will be affiliated with a primary care provider and can receive referrals through that mechanism. That's not the only way that they can access home and community care services.
Okay, the next question is, one of the things we've heard is that patients receive different levels of care depending on the area of the province that they are in. How will you be ensuring equity of access and service to all citizens across Ontario when their services will now be distributed across more organizations to manage, oversee contracts, and performance and fund?
Thank you for that question. It gives us the opportunity to reflect on the importance of equity of access to care in the home and community care world. We know that some of the care allocation opportunities that are made today are reflective of a history of perhaps funding levels in particular parts of the province. We also know that we don't have as much data about home and community care services as we do about other parts of the health system. So one of our shared system challenges, I think, over time is to better understand what information about a population drives their use and need for home and community care services in order to better distribute resources around the province for home and community care. And that will be one of our shared challenges as we look at Ontario health teams more broadly as well, and their use of their funding to best support their population. In the short term, we will be working with our current LIN partners in home and community care as well as Ontario health teams to find the right balance between promoting equity of access and equity of outcomes through guidelines with respect to service allocation, for example, best practices, continuing to review those guidelines of care and what impact it has on outcomes. So that will be an important consideration as we move ahead. We know that some parts of Ontario health teams may not be as familiar with home care as others, and what are the supports that we can put in place to help them in their care decision making will be very, very important. There may also be additional role for Ontario Health and the ministry as we look at that issue of consistency in the years ahead. So it's something we're very open to continue to look at, engage with our partners on, because of the importance that we place on the consistency of, on the equity of access, and sometimes that's measured through consistency of care as well.
The next question is, during the transition period, will the NRI CHA assessment continue to be the standard required tool for assessment / care planning?
It's Amy again. The suite of assessment tools that is used in home and community care in Ontario is a leading suite of assessment tools around the world. It's one that's very, very commonly used in Canada, and it's a very effective tool that's constantly being updated by the practitioners and the developers at the University of Waterloo and others. It's also a tool that's not widely understood and can be used more effectively in some cases than it is right now. There are a range of tools. Some of them are short, some of them are longer, and their use can certainly be better tailored to the needs of home care clients based on their individual circumstances. We also know that there may be some clients who are receiving home care who don't need very much of an assessment at all because their home care need is driven by an acute episode or medical need that really will dictate their care plan in the home. However, the advantages of having a common assessment tool that everyone uses really speaks to the earlier question around equity of care and how are we measuring equity of access and equity of outcomes. The data available in the RIE tool for an individual care planner and for system planners, both locally and provincially, is extremely valuable. The ministry uses that data for our planning purposes as well as to meet reporting obligations to the federal government, who is, of course, a contributor to our funding for home and community care specifically, as well as more broadly in the health system. So certainly we are looking carefully at the importance of having a common assessment tool. We know that some OHTs have proposed alternative tools. I think that's in quite a small number, or are asking when it is most important to use the tools and when they can be used most effectively, and those are certainly conversations we're engaged in.
Okay, the next question is, how do you plan to address the PSW recruitment and retention issue?
I'll just maybe start off. Thank you for that question. As we noted in our remarks that the proposed legislative changes that the minister introduced today are one pillar of a variety of different improvement opportunities that are being pursued. We're under no illusion that proposing legislation, regardless of how important that is going to address some of the chronic plan with our partners at Ontario Health and with other partners to look at health human resources shortages on in a more comprehensive way. Obviously, personal support workers is a leading example of where we can probably do better as a province in making sure that we can improve recruitment and retention rates. And there are tactics such as a model that we're calling client-partnered scheduling, which is a mechanism which provides for a more welcoming and sustainable work environment for personal support workers. This idea that the way that that work is scheduled, rather than being 1 hour in the morning and an hour in the afternoon, really bringing that scheduling to a model that can actually create a more predictable work regime for personal support workers. That in and of itself is unlikely as a standalone to address all the shortages, but as an example of one model that we are pursuing in partnership with the LHINs to make the work environment more attractive for personal support workers. But there's a lot of work to do because the problem requires a pretty multi-dimensional solution. As with all of our work, there are different people have different preferences, and we want to make sure that we're looking at the full range of options to address broad health human resources issues with likely a priority on the personal support worker challenges that we're seeing.
Okay, we only have time for one more question, so this will be the last question. What about the communities that do not have an OHT right now? Should people be concerned about their health care?
Absolutely not. I will just say that there is a constant intake and assessment process of being able to hear from new and upcoming Ontario Health teams of how they want to transform care in their local communities. Those dates and the process through which that intake and assessment is done are typically available and have been available through connected care updates like the one that you've received today. And as we've been clear about, our goal is provincial coverage. It'll take some time to get there, but going back to the legislative regime that's being proposed, it accommodates both the integration of home care into Ontario Health teams as defined under the Connecting Care Act, but also into health service providers such as hospitals and primary care organizations and community support service agencies. So, I think at the end of the day, patients, caregivers, and others expect us to better integrate services so it's easier for them to receive their care and navigate the system. And at end state, we see that happening in an Ontario Health team, but along the way, opportunities should be pursued around how services can be closer knit together. So we don't want any community to be disadvantaged because they may not have an Ontario Health team yet. There's a process to ensure that you could be considered for that on an ongoing basis. And during that process, all of our goals should be to improve the care that people expect from us. Deputy, I'll give you the final word on this.
Yeah, thank you. It's obviously a lot to absorb in a single Tele Townhall. So we're looking forward to further interactions and continuing to answer your questions as the legislation proceeds through the legislature, we'll obviously get your feedback in formal and informal ways. And I think, we're excited about the destination and building the connected care system that our patients and caregivers and families want. We know we need to work with you to make that a reality and to manage through an orderly process of change. And I hope you've gotten the sincerity and the thoughtfulness which we're approaching this change. So look forward to future discussions. And we will be sure to, as I say, post this, the Tele Townhall on the website, and keep your questions coming, and we'll look forward to answering them. And I hope you enjoy the balance of your day. Thank you very much.